Opinion columnist with the Boston Globe. Thank you for joining us today for a conversation about the future of federal grants and funding, which obviously puts health equity at a crossroads. I'm joined for that conversation by three subject matter experts to my immediate right. Joanne Suarez, founder and executive director of the Prospera Institute. Am I saying that right? Prospera? Prospera, I figured. Prospera Institute. Then we have Dr. Megan Cole, associate professor at Boston University School of Public Health and co-director of the BU Medicaid Policy Lab. And of course, Michael Curry, president and CEO of the Massachusetts League of Community Health Centers. So let's dive right in because we don't have a lot of time. And this is a very, very rich topic, obviously. I want to begin with one of the most pressing and foundational issues, and that's Medicaid, obviously, because when we discuss health equity and federal funding, this program is central. So, of course, as we all know, a range of structural changes are being proposed to Medicaid, which is the joint federal state program that covers more than 70 million people in the country. Just this morning, there was an op ed in the New York Times. I was just talking to Megan about this, that about a very conservative senator, Josh Hawley, basically coming out in defense of the program, which tells you, a lot of the state of things. So, Megan, let me begin with you. And please, Michael and Joanne, feel free to jump in after Megan with your thoughts about Medicaid. But can you please walk us through who Medicaid serves, what is it, and why it's such a critical pillar of health equity in this country?
Yes, absolutely. So first of all, it's so wonderful to be here with this panel, and what a wonderful event. So Medicaid has received a lot of attention, most recently with proposed cuts to the federal budget, really kind of laying on the backs of the Medicaid program. And I think before we kind of talk about like what those are and what that means, I think we first really have to understand, well, what is Medicaid and kind of who is covered by Medicaid. So as you mentioned, it's our health insurance program for low-income Americans, and it covers over 72 million people across the country. So that's half of all children, nearly half of all births, including more than half of Black and Hispanic births. It also covers the majority of community health center patients, and it's the single largest payer for services like mental health services and long-term care services. It also serves as a secondary payer for a lot of people who have insurance, but maybe their health insurance isn't good enough. So they may have the need for additional treatments or home and community-based services that just aren't available or affordable through their health insurance. So it's really not this small program. It has really wide reach, and it affects so many people. And I think also important to this narrative is that when we think of those people, these are people who, if they can't work, are working. So 92% of all Medicaid enrollees who don't otherwise have a disability or have caregiving responsibilities are currently working. So when we think about kind of these cuts that are being proposed in the Medicaid program, it's really on the backs of these people that we're talking about. And I guess kind of to your second question about kind of what is being proposed in this this bill, there's a lot of kind of wonky policy things in there, but I'd say kind of really at the core, there are kind of two key changes that will really be detrimental to the Medicaid program. First, it's really kind of a shift to states as we think about how the program is financed, which has huge implications for cuts that will therefore need to be made at the state level. And the other piece of this is really making it increasingly more difficult for those who are eligible for Medicaid to remain enrolled in Medicaid through things like work reporting requirements and increasing frequency with which you have to show that you are eligible for the program. And all those things collectively, we know will reduce rates of insurance. About over 8 million people will remain uninsured because of these changes, and will have huge implications for the health of those people who lose their coverage, where we know the Medicaid program has had huge impacts on increasing equitable access to care. And all of those benefits will be reversed through these kinds of changes.
Just real quick, can you give a sense of that impact on health equity? How has it transformed lives? Do you have a data point? I mean, not to put you on the spot, but like, do you have a data point, at hand about just the impact specifically on, underserved populations?
Right, so Medicaid, by definition, serves people who are lower income, and we know there's vast evidence to show that Medicaid and gaining Medicaid coverage does everything from improving mortality. It improves not only health in childhood, but throughout your adulthood and lifespan. It improves economic mobility. We also know there's a lot of kind of shorter term health gains there too when it comes to cancer treatments, prescription drugs, access to mental health services. Equity in all of those things improves because of Medicaid and Medicaid funding.
Michael and Joanne, anything you want to add to the Medicaid conversation?
Maybe just, and I love Megan's framing of who's impacted by any potential Medicaid cuts, but I like to give a little history too. When you think about Medicaid and Medicare, often when I teach classes, I'll reference the Civil Rights Act, 1964 Voting Rights Act. People don't often recognize Medicaid and Medicare as civil rights bills because many of the hospitals in this country were segregated through the 1960s. And it was the tool using the financing of Medicaid and Medicare to force many of our hospital systems to integrate. I think that's important because that's the grounding that this law has a root in civil rights. Two is, I think it's interesting we think about Medicaid and its impact. I always remind my students when I teach this, I said, I want you to think about this for a minute because we talk policy all the time. But think about before the Affordable Care Act, over 40 million people didn't have insurance. What does that mean when 40 million people, so all of you who are privileged and have the luxury of having health insurance, know that when you go to the doctor, you don't know what that actual visit costs. That when you go to the pharmacy, you pay your copay, you don't know what that drug actually costs. You don't make a decision between paying your bills, in most cases. In some cases, you probably do. But in many cases, you don't have to make that same choice between that pain in your side that could be stage one, that if you went to the doctor and had a primary care provider, you could have got it resolved, but you don't have insurance, so you don't go to the doctor. And that's your teeth, that's your eyes, that's your substance use disorder, that's your overall health. So I remind people Medicare was an expansion, which got us over 20 million people now that are still without health insurance. That's unacceptable. And we know, and I have the blessing of meeting with Secretary Walsh frequently, our Medicaid director, Mike Levine, just this week. And I always say to them, and they appreciate that I say it, pay now or pay greater later. Because if you don't insure them, if you don't provide them coverage, you're going to see them in the hospital emergency room where it costs more money. And by the way, they'll die sooner. And there's a cost to society when they're sicker longer and die sooner. So just the framing that Medicaid really matters and the implications of cutting Medicaid, I'll talk later about health centers, but has an overall implication on all of us. So you may think, well, that person without Medicaid is a personal thing, right? If they don't have Medicaid, but you're going to pay for it. Sure. All of us pays for it.
Right. Joanne.
Yeah, I'd like to add, so as I'm hearing you, give your description of what Medicaid does for our community. So my other hat, I'm the senior program manager for the Fetal and Infant Mortality Review. And if you know, majority of Black and Latina women are the one that experience racial health disparities when it comes to infant deaths. Massachusetts is actually the state with the lowest, but I think about all those women that I'm going to be serving in collaboration with my colleagues at BPHC. And I guarantee you that most, if not all, are on Medicaid because that's how they get the medications that they need. That's how they get the treatment for their babies who may be preterm or don't make it to term at all. And it's just helping me think about, how do I upskill my team to be able to have those conversations when we are face to face with families, grieving with them, but also communicating to them that this problem is bigger than us.
Yeah. We will definitely circle back on that a little later. But Michael, community health centers obviously are very often the safety net for millions of people. How are health centers preparing for potential Medicaid changes, but also research funding freezes, right? Let me bring that part in. How are they preparing to weather the storm?
So, I tend to be a little bit off the message because I'm still using bad words like diversity, equity, inclusion, racial justice.
This is a safe space.
So I'm going to tell you, I'm still using them.
Good.
And I'm not burying words. That being said, I understand why people are making some difficult choices, but some of us are really holding fast What I worry about, and I just give the framing of civil rights to, we talked about Medicaid. When you think about health centers were born out of the civil rights movement. These were freedom summer activists who were physicians, who were civil rights activists providing medical care to the civil rights workers like Jack Geiger, Count Gibson, for those physicians in the room who know those names, Dr. Smith in Mississippi and Dr. Hatch, who was at Boston Housing Authority. They created this movement, Elsie Dorsey and others, and they gave birth to this movement to do exactly what we do today, to treat poor people, underserved people, racial and ethnic minorities, to dismantle racism, to deal with the social determinants of health, the fact that people are sick for a reason. Some folks in the room know me quoting Rebecca Lee Crumpler all the time. They seem to forget there's a cause for every ailment, and it may be in their power to remove it. There's a reason why they were sick in Columbia Point in Dorchester when that first health center launched. It was racism. They didn't have access to the same jobs. They didn't have the same opportunities. They were locked out of economic wealth and opportunity. They were mass incarcerated, all those things. Yeah. And then go across the country, right? Mount Bayou, Mississippi, the second site that opened in 1966. So what we're facing now is over half of our patients, as Megan said, across the country are served by Medicaid. Half of our patients are Medicaid patients. In Massachusetts, it's like 47%. So it's about 386,000 of our patients here in Massachusetts. So just the framing of this, we serve 1 out of every 10 people in the state. Wow. We serve, if you're in Boston, the city of Boston, we serve 1 out of every 2 people in the city of Boston get their care at community health centers. That's 20 in the city and 50 in the state health centers, 285 sites. We rely on Medicaid. In Massachusetts, 31% of our revenue is derived from Medicaid, 40% of health centers across the country. And if you are in parts of the state, if you go out to Western Mass, that Medicaid number could be higher, higher in patients and higher in revenue. 80% of our patients are publicly subsidized around Medicaid, Medicare, Medicaid, and other programs. This would be devastating. So you might say, well, you know, we can afford to lose a health center. But I tell you, from my mother, like I grew up in Lenox Street housing projects. My mother was a Medicaid recipient, so we got Medicaid. So I want you to have a face for Medicaid. Medicaid, we were a health center patient. I got my care at Whittier Street Health Center. We relied on Medicaid to get all that care I talked about earlier, our eyes, our mental health, our physical health. But for that, we would have seen even greater sickness in our household and potentially death and in our neighborhoods. So think about that when we think about these really high-level policy issues, that they will result in the elimination of health centers across the country, which then means the economic engines, as Jessica just talked about in Brockton. You eliminate Brockton Health Center, you eliminate, I think, the first or second largest employer in downtown Brockton. Mattapan, Lowell, Lynn, Lawrence, Springfield. This is a existential threat to all that we believed in 1965 and all that we believe in now.
Just to give sort of a sense of the, you know, the research funding freeze, right? Like that also is another layer.
If I can, I forgot to mention the research. So research matters. Joan Reed is here. Joan Reed, right, raise your hand if you're in the room. Dr. Reed, yes. Can we give her a round of applause? Harvard Medical School. She understands this much better than I do. But you know, for health centers, we are we are very much locked in with our research partners to do that cutting edge research, that biomedical research that is saving lives and will save lives in the future. Fenway Health, as an example, that is being told to hide their words, right? Don't say gender affirming care, don't say LGBTQ. I want you to think about, in one day they lost 5 grants. 12 of 27 grants are now gone, over $1.8 million in funding. And part of that, Dr. Reed, was prevention and intervention for adolescents with HIV, right? That's the research. So when you cut that research, this is another example, pay now or pay greater later, right? It's not just about money. When you don't invest in research that then saves lives, you're costing lives later on. So Fenway's an example, but we have research across our system of health centers. We are deathly afraid that our partners like Harvard Medical School, Harvard School of Public Health, BU, others will lose funding and then will not be able to do that kind of research.
Just again, to give more context about this, obviously this federal research funding freeze is particularly targeting the National Institutes of Health. According to CNN, in the first quarter of 2025 alone, NIH research funding was slashed by $2.7 billion, with nearly 800 research projects terminated in under 2 months.
$45 billion I think is the total figure of NIH research. 3.3 billion of it comes to Massachusetts. So we rely on that research in Massachusetts.
That's crazy. I mean, again, just think about all the layers and the, I guess, multiplying, you know, the effects. It's just basically you can't calculate them. You know, you're talking about Brockton. That is an economic engine in Brockton. Employment, you know, unemployment, all of that. So anyway, let me bring you in, Joanne. Let's talk about your institute. You've championed community-driven solutions. You know, from your experience with the Prospera Institute, I mean, just tell us about your work and why you decided to launch this initiative. And, you know, what did the impact of these cuts mean to you? Sort of connect all these pieces at that granular level for us.
Yeah, absolutely. I think my primary concern is thinking about like the direction that science is going, like with my research hat on, like what is going to be the future of science for us that really appreciate this discipline and that we know that this discipline saves lives and it's evidence-based, and we wouldn't be here if it weren't for some of those advances. My organization actually was born in the halls of Harvard Medical School while I was training in bioethics. And for those who don't know, in short, because I'm not going to give you the philosophical, bioethicists or ethicists, we focus on healthcare ethics. So we ask the big questions like who gets care, when do they care, and why does that matter, and how do we distribute care in a just way. So when I was at the medical school in training, I was the only Afro-Latina in my program, and my background is as a community health worker. And I said, oh my God, this tool, we could really mobilize it in community and use it to transform health outcomes, me thinking with my health promoter hat on. And at the time, I was working for the mobile health clinic at Harvard, the family band. So I was sitting with patients one-on-one, listening to them and doing these basic primary care screenings so we can get them from point A to point B. And that's when I started thinking about Prospera, like how we kind of operationalize that and make sure that we're using those tools to empower communities in their health. And we actually were born in a time like this in uncertainty. We were born during the pandemic. So I bootstrapped, and I'm still bootstrapping the organization because building a community-based research organization was intentional and it was by choice, because I saw the benefits of academic institutions and the benefits of sitting on hospital committees. And I can be a translator between community and the institutions. And I wanted to lean into what was my subject expertise. I'm good at building systems, and I'm good at translating across systems. And we've served 200 people to date. We have an annual symposium where we bring bioethics directly into the community for free, because bioethics conferences can be $4,000 to $5,000. So we wanted to bring all that expertise into the community, because we're often talking about these issues, but communities are not at the table. And in my line of practice, community is where I get my wisdom. Like I could sit down with the mamita and talk to her for an hour, and I won't get that kind of knowledge in a classroom. So we really value that. We just launched a pilot called Areitos Cafe, which are like fireside chat style. We really break down these really complex philosophical bioethics concepts into a case study and dilute it so that information can be digested by the community members. And we do an assessment where we see if that has changed their knowledge. And once we see that, we ask them, well, what question did you ask differently? Have you actually used this in your day-to-day in your healthcare exchanges? And in last symposium, we got 48% of people were like, yeah, this is my second year coming. I'm seeing that I'm asking questions differently. I'm understanding how systems work. So it might be like a big umbrella what we're doing, but our research is really targeted to continue changing health outcomes like I did as a community health worker. Yeah.
So we're running a little bit late, and so in the interest of keeping things moving, I have one sort of final question for each of you. If you can, well, the final question is for all of you, but if you could just sort of answer it in a concise way. I know it's a big question, but, you know, given the challenges that we are discussing here, right? What kind of support, whether it's policy advocacy, philanthropic, or grassroots, would make the biggest difference right now? Again, I know it's a big question, but like from your perspective, talk about what would make a big difference. We're not from all of us to take away. What should be our takeaway? What should we do? Megan, you can start.
I'm happy to start. I mean, it feels like we're in a very paralyzing moment right now. So I think this is an important question. And I'd say, I think really leaning into how important some of these programs are that we're talking about in both red and blue states. Medicaid as a program affects so many people and is wildly popular. Community health centers, very similar in all states, very popular, very cost effective. I think really trying to communicate the importance of that, I think is powerful. And I think we're seeing some like political like resistance to some of this from places that might be surprising because of people using their voices and communicating the importance of these things.
Joanne, you want to say something?
I think one of the things we have been thinking about is like collective funding models. Like how do we innovate with our partners and apply to grants together, do fundraisers together, like give each other a section in our newsletters or in our social media so people can see like we're uplifting each other's work. That has been very beautiful for me, and with the people that I work with, my partners, it's forcing us to think differently. We like kind of the struggle. This is like the time we thrive in. So I'm very fortunate for being like, oh, let me call up somebody and let's think on this together and let's just do it. And if it fails, we learn. And if it works, then we know it works.
So leaning on the power of community. I love that. So Michael.
Maybe quickly. So one is to Megan's point, health centers are about a 10% savings of patients who get care in other settings. That's 1.5 million in Massachusetts in savings each year. So we know it works, right? It's the front door to our healthcare system. They shouldn't come in the back door and be in emergency rooms. So investing in, being conscious of the role health centers play. I have the blessing of being in three things I'm most proud of next to my kids. One is Harvard School of Public Health has a Community Coalition for Equity and Research. Karen Emmons, Rebecca Lee, lay people come in, they meet with researchers, they engage them around health equity and justice, and then they become activists all across the state on issues, including what these cuts will mean. So we need to empower people from communities to be at the table and have the language of research. That's one. Two is we launched the Mass League. Mass General Brigham gave us 1.5 million. The state legislature gave us 5 million. We launched the nation's first Institute for Health Equity in the nation at a primary care association. That is what we call, and I get really giddy when I say this, emancipatory research. So that means we don't wait for ivory towers to tell us what they see in the data, what questions they have. They'll come out of community with our community-centered boards, with our patients, with the data that we have. Then we invite in partners and say, can we look at cancer? Can we look at diabetes? Can we look at substance use disorder? We're doing that now with some phenomenal partners. Last but not least, we have probably 4 members of the Health Equity Compact in this room. So this is inspiring and hope on the other side of this 2 to 4 years of the clock turning back on all that we fought for, because that's what's going to happen. Yeah. Is Dr. Reed, Dr. Vora, Dr. Ojukutu, Rosa Colon-Colaco in the room, and Lindsay Tucker. 85 leaders of color came together 3 years ago and started the Health Equity Compact. Now, I say this all the time. If women in this room ran everything, we would not have a maternal health crisis in this country. And I don't even say that for a clap. Because if you ran everything, you would prioritize women's health. If people in this room with a disability ran everything, we wouldn't have the disparities in disability that we have right now, because you would make sure people have access to services. Right. So we now have 85 leaders of color who run stuff. I won't say the other word. They run stuff like Dr. Reed and can come to the table and push policy with the legislature. So although my colleagues across the country are calling me and they're feeling devastated by this moment we're in, we have to know that in Massachusetts, we're not where everybody else is. We have hope. We're gonna lose some ground. But my message to us as policy folks, as activists, as patients, is we got to wait for the recoil, if that's the right word. That on the other side of this, we got to come back stronger. We got to aim higher than even where we were, because this system sucked before Trump.
True.
This is, anybody will tell you, we didn't pay well, we got people stuck in the wrong settings. All those things were real. Let's come back even stronger after these 4 years.
Well, that's a great message to end it on. Before we all, thank you. Thank you for sharing. I feel like we could have talked about this all day. Thank you for sharing your expertise. Before we break for lunch, I want to welcome to the stage Brian Ford from Sanofi, who's going to say a couple of words.
First and foremost, thank you so much to each of you. I just walked in and caught the end of that, and I can tell you, I heard some comments, the paralyzing moment that we were in, that was quite an impactful statement, but then to hear the back end of this, it wasn't good before this. So what are we all going to do about it? And I can tell you, I'm on calls like many of you. I'm in meetings and I'm on calls every single day, and we're looking for the opportunity in the chaos. And I can tell you, it is inspiring to come down and know that we've got this many faces. I didn't know there'd be this many faces in this room. So just a huge thank you. And for those of you that are online as well, a huge thank you, because you're committing your time, which is one of the most valuable resources that we have, your time and your brains. I mean, that is what we need. We need more of that. And the fact that you have so many of you have come together in this moment, when many of you could just say, hey, it's too chaotic, I'm just going to go do something else until this blows over. That time and energy that you're putting into this is extremely appreciated by so many that are not in this room. And so I just want to make sure that you heard that actually from me. As I come down here, I'm inspired. Now I get to go back to a lot more Zooms here in a little bit that will suck the life out of me for the rest of the day. But I will take a little bit of this energy that we've had from the stage and a little bit of the energy from the room for the rest of my day. I wanted to start by saying a huge thank you for being here. We are honored to be a part of this for last year and this year. It's honored for us. Nothing makes me prouder than to see presented by Sanofi, if nothing else, actually to have a space where you can come and have these conversations, have these debates, by the way, also. Because I think the health is in a lot of the debates as well, because I don't think that any one of us has the answers to the challenges that we're facing because they are too complex. But the health is in the debate. The value is in the debate, and knowing that we're all doing it for the same reasons. And you're doing it in a place, by the way, that there's probably no better place in the world to do it than here. And I'm not talking about this building, by the way, although I think that. I'm paid to think that. But this location has probably had more impact around the world on creating innovation for patients, transformative therapies for people. But what you're talking about is the most important part. It's that last mile. How do you get that innovation into the hands of patients to transform family members' lives, not just patients' lives, family members' lives, health caregivers' lives? It has a huge impact. The lack of access to the innovation that we may produce, or many companies around this area, over 280 some biotechs in this space that every day are trying to turn science into hopefully a life-changing therapy that in many cases might not ever reach the patient that it needs to reach. That last mile is the hardest part. We actually say today, the easier part today is actually the innovation side of things. And my R&D colleagues in the building next door would actually agree, because nothing is more frustrating to them than whenever they do something truly transformational for patients and to know that it gets into a fraction of the patient's hands that it actually should. So we're in the perfect location to be having this conversation, but thank you for having this conversation. Thank you for pushing us and for everybody else. We are in the space, so we don't just do the innovation side of things. That is a big part of what we do. But a big part of what we do also is engage in the conversations like you're having here as well, because for us, it's equally frustrating that these therapies do not get into the hands of patients, because we get to see the stories every day, like many of you do, when they do. I mean, this morning, it was funny. I was reading a text this morning, and they come every single day from all over the world. But I was reading a text this morning of a patient that suffered for 8 years, and she was a professional painter, by the way. She's an artist. She suffered for 8 years, so much so that she could no longer paint anymore because of the disease was so disruptive to her life. And it took 8 years to get a proper diagnosis and a proper therapy, transformed her life in the matter of a month. She's back to painting now, opened up her own art exhibit, and one of our team members just happened to be visiting that art exhibit and read what the actual thing said beside the name of the painting was about the pain of itch. It's what a lot of people thought. It's atopic dermatitis, which is a debilitating disease state that a lot of children are born with. And this individual bought the painting, by the way, spent $1,400 to buy the painting, so she's doing well now. But the connection there with another human, he was just having a conversation with her, and her story came out in that conversation that she'd suffered for 8 years. She should not have had to suffer for 8 years. And I bet everyone in this room could tell hundreds, if not thousands, of stories just like that. So again, I just want to make sure that I expressed my sincere appreciation for the conversation that you are having. Anything that we can do, and this is my ask back to you, is anything that we can do to help. You may not even think of a pharmaceutical company as we commonly get labeled. As we can be helpful in these conversations, ask us. Because I don't think we get challenged enough to be engaged in these conversations. We get put to the side in a lot of conversations, saying, we'll get to you when we need your drug, but we need to be engaged in these conversations as well, because it even starts with clinical trials. Where are we doing the clinical trials? Which patient population are we doing the clinical trials in? We still have a huge issue with the fact that many of our drugs come out and have not been studied in some of the patient populations that they will actually be used in the future. Now, we are making extremely good headways there because we are now incorporating patients into the design of our trials at the very beginning of things. We've made commitments in reference to ambitions that we have about where we do our trials, patient inclusion in our trials, but this is just scratching the surface. So my call to action to all of you is please keep having these conversations, especially in times like this. Don't ever be discouraged because I think there's a lot of opportunity in moments like this too, because I think you said it extremely well. The system wasn't great before this chaos. The question is, will it be better after this chaos? In the moment, it doesn't feel like it. But I think chaos also creates opportunities as long as smart, brilliant, passionate, committed individuals like you all come together and have the difficult conversations and challenge those of you, all of you, challenge all of us as well, because we're in it with you. So a huge, huge, huge thank you. I stand in between you and lunch, which is a really difficult spot to stand in between. So I want to thank you again for being here. Thank you for including us actually in the conversations as well. Thank you for the panelists, and please have an amazing rest of your meeting here. Thank you.
Thank you so much.